So, let's take a look. The dog's easy to draw. Yeah. You mean this dog?
Yeah. Like there are hounds which have way more, way better than these types. But
oh yeah, for sure. Sure. Yeah. I mean, there are also many other creatures, like sharks, for example, have obnoxious sensing capability where you just think, how the hell can you smell a drop of blood from, you know, whatever distances where that single molecule from the blood came from. Yeah? So it needs to be an obnoxiously high sensitivity, but it's not absolute measurement. It's always a relative measurement. So they are looking always for concentration gradients. That's the way how these animals achieve this astonishing sensory properties, as far as I understand it. Okay, let's continue a little bit with something which is more reasonable. Prevalence, test sensitivity, specificity, just a different use case, because trisomy 21, we had this as one of the cases in the beginning of the first introductory slides. So what you see here, and I'm telling you also that because in Germany, these novel tests, prenatal tests, are not being covered by the healthcare insurance. So you're pregnant, you want to know if you have a baby which unfortunately has some kind of a genetic disease. Nowadays, you can also get that covered, these kinds of tests in Germany. So what you see here is the positive predictive value for, what's this? I don't know anymore which kind of a test this was. I would need to look this up. Sorry about this. But for the exercise, it's sufficient that we have here the axis here. This is age. So you know, the higher the age, the more risk you're taking to give birth to a child. Well, and if you have a look now just for trisomy 21, there are also other forms. The test sensitivity was, you know, close to 100%, and specificity also close to 100%. But because the prevalence is low, right, we see that the positive predictive value again is pretty low. But you also see that there's a trend towards way beyond 90% positive predictive value when you're older than 40, which again is a highly prevalent case because many women decide to have babies at a rather light stage. Okay. And here test makes very much sense, same test, but for a different population or different cohort where the age is something just 18 years or something like this, you know, test is useless. So again, that's a different dimension. You know, we just had about the discussion SARS-CoV, you're positive, infected or not. This is now a different dimension, same test. In the one case, it's so it's all clinical case, right? Risk group predicted that potentially you have trisomy 21 with your baby. But for the young people, test is completely useless. Yeah, playing the dice is equally good. But for old patients or old suspected cases of trisomy 21, it makes very much sense. And the same is also more or less true for other of these trisomy cases. So again, you know, it depends on the setting. A test can be reasonably well or not. Would you like to know this as a medtech engineer in a company? Of course, because you have to evaluate what's the market size. The typical, you know, number crunching of the startup companies, we make 5 billion. This is my total market. And then we have now a few more acronyms. And you're selling, yeah, my accessible market in Germany are 40 million women. Okay, but then we take away the 18-year-olds, the 22, the 26, the 20, 30, and blah, blah, blah. And we also take away anyone else older than 50 because usually they don't get babies anymore. So we remain with, you know, something like people between 35 and 45. And this is your real market size, okay? But if you don't know that, you end up, of course, with a wrong number. Later on, we're going to also look into acute myocardial infarction as a use case. I think I mentioned this already. You have a muscle protein called troponin. When this troponin muscle protein, which does not exist anywhere else in the body, but in the heart muscle, can be found in the blood. That means cells must have been ruptured. And that's the reason why you find that protein in the bloodstream, right? And this is the most important test that we currently have to detect actually acute myocardial infarction. But the question is, do you care about the false positives? No, you don't, as you're going to see it. So, question of rule in versus rule out, if you remember our graphs that we were having. Because if you're treating someone who was then, 2 days later determined as a false positive, yeah, okay, but I haven't missed anyone. It's an acute care thing. You don't want to miss anyone who had a heart attack. So you probably will shift your thresholds, what you say, I want to be completely sure that I get everyone who has a heart attack, plus a few false positives, but I'm not going to lose anyone.
Or the person didn't have a heart attack.
I may take this question to one of the following slides, and then you're going to see why, how the answer looks like. So there are many other reasons why you can have elevated troponin in your bloodstream. And most likely, I would say 30% of you have already troponin in your bloodstream. You're not even aware of it. Why? Because you had an inflammation stage, you had infection. Same story. But you have a different kinetics on how the troponin rises over time. And that is very typical for someone who has an acute myocardial infarction as compared to someone who just had an inflammation. And then the typical example also on mammograms, the positive predictive value of the mammogram always being sold as the gold standard to detect breast cancer. Again, depends a little bit on the case, but the range goes from 3 to 60%. And there's always the criticism, under which conditions does a mammogram make sense? Just because you see a little bit doesn't mean that you have cancer, okay? And that's actually true for many other types of cancer too. We're going to discuss also cervix cancer as a use case. So anything related to the Gebärmutterhals. Also a very female-related case, but very well tested for the past decades. And again, you're going to see, just because you have a dysplasia, some change, some lesions, you're far away from cancer. And again, what is your market size? And you will realize relatively quickly that cancer is not only cancer. Cancer could also be just dysplasia, and it even just disappears in most of the cases. And that's also the criticism why mammography always is a little bit in the shades when it comes to the quality of results. My question here would be, what could you do to confirm the test with a gold standard? What could be a gold standard for trisomy, for myocardial infarction, for mammography? I mean, I wrote it already down, but just have a little bit of a discussion. What could be the best test for trisomy 21? The gold standard. Well, you give birth to the child, and then you see. But postnatal, okay, you're getting already into this regime where it becomes maybe unethical, or yeah, you just want to know if my child has an issue. But then all the consequences are there, so there's no going back anymore, yeah? Or you just give away your child, or anything like this. I mean, there's all kinds of weird things going on because this is an extreme situation. It's a very extreme situation. Acute myocardial infarction, what would you do here to just make sure that something really happened? Well, for this, imaging has a solution which is really, really good. That is invasive. So you're adding contrast agents, and you do basically an imaging, continuous imaging of the heart as it pumps. And then you basically see where the contrast agent cannot go through an obstruction because this is where the blocking has happened. That is quantitative. Yeah? Here, imaging is really outstanding, but it is invasive. I mean, even the probes you're using, they cost a few $100 just to put them into your heart and to place the contrast where you would like to have the contrast. And you need to have a rough idea already what type of a heart attack it was. Mammography, well, Here it's obviously histology. So, you would need to get some biopsy sample out of the breast, and the pathologist has to look into the details, hoping that you really placed your needle right there where you saw the contrast in the mammography before. Sure.
Then, how do they understand? Do they try to kill it and it doesn't die?
Okay, so pathology is always, being argued. You can replace pathology with some nice imaging algorithms and so on and so forth. I have strong doubts that this will ever happen for a number of reasons, because a pathologist is at the same time a physician, and the physician has a lot of implicit knowledge. So if he knows a little bit about your background, then he will decide maybe different on the same result, because he looks into the tissue he was checking on, because he knows something about your background. Yeah? An algorithm to train him to also integrate also these other pieces of information is already challenging, because this usually requires decades of training and experience and so on and so forth. The other thing is also that cancer is not something which changes linearly. And in most of the cancer, so most of the cases, as you're going to see later on, cervix cancer, for example, just disappears by itself. So at which point in time do you really start to treat? Because there's always this cost benefits, and you should not harm your patient. So which test provides really the relevant information? And we started pathology experiments, I think now 2 years ago. I had no freaking idea what I was going into it. But we have learned now a lot, in particular on cervix cancer. We also know that the traditional way of doing AI, just look for the pattern, is completely useless. Why is that? Because it's the way how the pathologist discriminates the different stages of cancer. And this is exactly what you would like to have. If you have early stages of cervix cancer, you don't treat, because the likelihood that this is all going to disappear anyways is way more than 90%. And only when you reach a certain threshold, and now it becomes kind of interesting, what is the threshold? They call it stage 3. And even when we look into a stage 3 cancer, let's assume we see 100 cells, which look kind of awkward, but 98% looks like stage 2 to 3, and only 2 guys look like 3 to 4. So the majority of the cancer cells still are in the status where you would not treat. So you could report a diagnostic result based on the majority. This is what the AI would do. Or do you just look for those 2 little cells? This is insufficient statistical power for doing any kind of algorithm work. But for the pathologist, he knows that this is the one. Go for therapy. So how to train that? That's actually challenging, because it's all a matter of statistical power. And we try to literally do algorithm work based on exactly the same workflow as the pathologist is doing. And this is not, deep AI, whatever crap. It is literally simple filtering. And we look for different functions, what he's aiming for. And only at a later stage, we're going to aggregate this to, give them a simple final result of it. And only when you do this, you really follow the workflow. That's also the reason why you need to understand the workflow of your potential customer. Then you don't get into this edge where you are producing something what no one will use at the end of the day, because they will never trust this result. And this extreme case, like stage 2-ish, 3-ish, maybe already 4-ish, is a perfect example. You have a look at it. The majority of the cells look like not treatment yet, but there are 2 cells. And the likelihood also to find these 2 cells in that one sample, from that one biopsy sample, what you've been receiving, so many things can go wrong. So you're not only taking one sample. For example, when you do breast biopsy, you are allowed, depends on the country, to take up to 5 samples or so. Yeah, just to make sure. But you know, anytime I punch something into a breast, I mean, this is not nice. The same is actually also true for men. You know, men can also have developed breast cancer. It's much rarer, but this is not funny. And you have to balance, of course, also the effects of the biopsy sampling, because there's always a bleeding event. I mean, you punch something into the breast, not funny at all. Okay, so you know, where is the trade-off, and where will you find the optimum remains to be seen. But now we have been talking a lot about women. What about men? Yeah. So men, they usually stop growing when they are something like 16 years old, with a few exceptions. And the one exception is our prostate. Yeah. And what is the prostate? It's that organ, you know, which circles Harnröhre, the urinary tract here. And the prostate produces a protein called a prostate-specific antigen, or PSA. And this PSA is actually being used to kind of support semen in flowing conditions. Yeah. So, and therefore, if you are looking for PSA, you should always find a high concentration of PSA in the urinary tract. That's perfectly fine. This is where it should be. But where you would like to have the PSA is in the bloodstream. Because if it goes in the bloodstream, you know that some of the PSA decided to grow more towards the other side. Towards the capillaries where your blood is circulating. And like 25 years ago, people said, this is the perfect cancer test for prostate. Because, you know, when the protein is there, the PSA, then something must have been grown dramatically. In the meantime, we know that this is all bullshit. Just because you measure some PSA in the blood could be also the result of some inflammation, some infection, or whatever it is. But where the test makes perfectly sense is when you have been truly diagnosed by prostate cancer and you're receiving a treatment, and you're checking then afterwards as a monitoring biomarker, does the PSA value drop, or does it stay at a high level, or does it even continue to grow in concentration? Because this gives you this gives you an idea about, did the treatment work? That makes sense, okay? And for this, it's the gold standard nowadays. Because again, what's the beauty of a blood test? It's not very invasive, it's accessible, it's economically, blah, 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 blah. Yeah? But there was quite a bit of a learning to get to this point. But the actual challenge is, you know, we don't even want to have prostate cancer. It's the same story like with mammography and in all the other preventive measures, what we're trying to do. And, you know, prevention is the best case scenario for cancer, because as you're going to see later on, when do we talk about cancer and cure? You will be a little bit devastated when you see the statistics on this one. But in this particular case, we talk about something which is a relatively high prevalence case. So usually cancer over all ages has a prevalence of like 1 to 100 cases per 100,000. Only breast and prostate has something like 700 in 100,000 cases. So prevalence is relatively high. And as compared to anything else what we have in cancer. Now, the problem is that most men develop actually a benign form of this is now called hyperplasia. So it grows, yeah, because it just grows, but it doesn't do any harm. And even if I have a very soupy-doopy hyperplasia, but I'm 90 years old, I don't really give a damn, because most likely I'm going to die anyways by anything else before it starts to be something malignant or anything like this. And if you again see here the numbers for ages, think about the trisomy test we had before. Does it make sense to test men beyond 50 years of age? Yes, it does, because then you have really a high prevalence. It's a high prevalence case for doing prevention testing, okay? And the older you're getting, you know, the numbers go even beyond 90% or so. But then, you know, does this make sense to even do a test at this very high age? Well, probably not. And so on and so forth. So now let's have a look here on the right-hand side. Sorry, this is in German, but this is the reality. And this is representative for basically all kinds of preventive oncology measures. There was 2 years ago, last year was a paper where someone did a meta-analysis on all kinds of reports with highest level of evidence. How good did the prevention work? It was devastating. Basically, it did not work at all. And why is that? So let's assume we have 1,000 men in a high-risk group where you do a PSA test, and you see that somewhat elevated. That's the easiest test we can do for the moment. And then you split up, those people who have actually nothing spectacular, and 240 will then also receive biopsy because I need to have a gold standard. Pathology is always the gold standard. Then you end up with just 100 men who receive a report that potentially this is cancer. Okay. Now you keep moving and moving and moving, and you end up actually with just 1 or 2 men who will be prevented from dying from prostate cancer out of 1,000 risk patient. This is the best prevalence case what we have. Okay, the best. Please.
I don't.
I will be careful here. I mean, this is the part where you either drip or you can keep it. So quality of life is here a pretty important part of that storytelling. It's not only about, yeah, you might have cancer, but this is really a situation where the quality of life differs significantly. If you get a treatment was not well planned, and you're dripping afterwards, and you have to wear diapers for the rest of your life. This is not funny. Plus, it increases also the risk of infections. You have no control anymore. And other issues. Plus, your lifestyle will change significantly. Okay? So, best case scenario, with respect to prevalence, which is always a big number for us, and very, very low outcome. A few words on the economics, just to give you a little bit of an idea of which numbers are we talking about. A PSA test is in Germany something like 25 euros, right? How much does a medtech company will earn? In a best case scenario, 30% or so. The rest goes to the clinician. MRT guided biopsy, it's like $2,000. Yeah, this is this stage. What you do here. Okay, 240 times 2,000. Can any society afford this? No. Just MRT is $1,000. PET CT, other modalities also every time it's 4 digits or anything like this. So that is the challenge what you're having. It's not only the prevalence issue, but it's also the economics. Simply speaking, the infrastructure. I mean, at the end of the day, you can always do anything, but what can society afford? So then, since we are already in the case of cancer, what about cure? So when is someone really cured from cancer? Ever thought about this? Anyone has a cancer case in his family? Probably many of you. Sometimes you hear your aunt and your uncle is now cured from cancer, but what is cure? And there are actually different definitions of this, and they also depend on what discussion do we have? Is this after diagnosis? Is this after treatment? And that's the usual one when we talk here about disease-free survival, meaning I have been treating a cancer patient and I'm looking for the next 5 years. Within these 5 years, there was no further sign of cancer. Then I call this recurrence-free or progression-free survival. And this is usually measured by 5 years max, because after this, there can be so many other influencing factors that maybe cancer returns, or it's a different type of a cancer. There is then too less causality to the original cancer what you had. Whereas cancer-specific survival, after diagnosis, specific type and stage of cancer, did you survive essentially a relative survival with respect to people who don't have any cancer, overall survival, again, after diagnosis, where you just do the ratio between the ones who died and the ones who lived. So there are all kinds of different versions of it, and you cannot compare these numbers, okay? And I would like to show you one case. I think I mentioned this already when we talked about regulatory a little bit. This was about CAR T-cell therapy. Did you have a look on CAR T-cell therapy? I'm not sure, I think it was in the other lecture. Okay, so what's the challenge here? CAR T-cell therapy is one of these new, columns of cancer therapy. They're super expensive, like 300, 500,000 euros or so. Pretty hefty price, but they're there. But they are so young that the regulatory body doesn't even know if they are working in the way you have been doing your studies. And so what they are asking now for is a so-called post-market surveillance, meaning, yes, I certify that you are selling now your CAR T-cell therapies and people get treated, but I'm asking you to check for 15 years after post-market if someone who has been receiving a CAR T-cell therapy still shows efficacy. So can I still see 15 years after the therapy has been given that these CAR T cells are still swimming around in your bloodstream, for example? Or can I still see 15 years later that these cells are actually still, fighting your cancer in this area where maybe you still have a cancer? So first of all, 15 years is a huge amount of time. If we're just reporting typically 5-year survival rate, and then this is cure, okay? So we don't even have statistics for this. Plus, find these patients after 15 years. Yeah, maybe the one guy's moving from New York to Florida or to China or whatever. And how do you get the data? Yeah, so this is a little bit of a challenge for any company working in this field. Nevertheless, they are pretty active in doing so. So, yes.
What were the expectations of the people who developed the program? How many people from the cohort of 1,000 risk patients did they expected to save? Like, what were the expectations or the logic behind why the program was launched?
I think there's always this big question: how effective are these prevention programs? So when I was about your age, there was always the big claim that doing Germany talking große Hafenrundfahrt, meaning you get a tube into your bump and you're looking for some polyps because they're indicative that there's also some lesions, some dysplasia going on, that this was really a breakthrough. Now, 25 years later, as I said, last year, the paper was coming out. It doesn't look like it was a breakthrough at all. You still miss the same amount of people, or people are not accepting to use this type of preventive opportunity, or. And at the end of the day, just because you can do something, right, doesn't mean that it will lead to any effect. So you need to have this epidemiology data, but epidemiology requires that you have a base of cases. So like for CAR T-cell therapy, where's the epidemiology? It doesn't exist yet because we simply have to treat a few thousand people or 100,000 people, and only then we see, was it really worthwhile?
So it was kind of promised that it didn't become fulfilled. They were expecting that the testing procedure will have much higher sensitivity and will allow to stage the cancers early, but just that didn't happen.
Yeah, because I mean, you're always starting off also in a clinical environment with a certain hypothesis, a working hypothesis, and then motivated clinicians try to push the limits, of course, and they start programs. They align amongst each other in different centers, and then there was a German-wide center or a global wide initiative to prevent prostate cancer. And then guidelines are being prepared based on best practice. But if they really have led to impact, you only know maybe a decade later when you have generated a substantial amount of cases from which you can learn retrospectively if that led to the 1 or 2 lucky guys who have been saved by this type of prevention exercise. Yeah. And that's actually really the challenge. I mean, how do you do this? Yeah. I mean, the best case scenario, I think I've shown you that, was quit smoking. I don't need to do a test. Just quit the smoking was sufficient. Nevertheless, my mother, she's smoking 2 packs of cigarettes and she has the lungs of a 20-year-old, according to her doctor. And she runs to the lung doctor, I don't know, on a weekly basis. I don't want to die because of cancer. Can you please stop smoking? You know, it's one of those things. But you probably know very related cases also amongst your family members. So this was the CAR T-cell therapy. And let's go back again to the females. Oops. Pap smear test. Pap smear test is like the simplest test developed by a Greek clinician in the 20s of the past century. And what you're doing is basically you just rub off the uppermost layer of your cells, and then you colorize them, put them on a slide, and you're checking, you know, how these cells look like. The color coding indicates if this is a grown-up cell or still a cell which is in development. And the nucleus size with respect to the overall volume of the cell indicates, for example, that you have a certain stage of dysplasia. And there are many more functionalities, and this would be of something which looks really, really awful. And the schematics basically indicate, you know, you have some kind of a dysplasia, which more and more develops into something which likes to grow out of its area where it should stay. This is the carcinoma in situ. So it is in its environment, but now the in situ is gone. It just starts to spread, and this is, of course, a worst case scenario. Here it says that you know, we are starting off with a viral infection. This is the human papilloma virus, and some of these strains show a massive blow on your genetic makeup. So basically, they really screw up your genes, and that leads with a certain likelihood to cancer. And the Nobel Prize was given here to von Hausen, a German physician, who were working on this hypothesis for decades. He said, I believe that viruses are the starting point for cancer. And no one was believing it. I mean, everyone was laughing at him, okay? Until he had proof, and then they gave him the Nobel Prize. And as usual. And I think he passed away last year, or was it this year? And at the very last phase of his super active career, he was even working on the working hypothesis that the type of food we are actually eating also leads to all kinds of different forms of cancer. I mean, there was no proof in this one. Maybe he went a little bit too far, but nevertheless, I mean, he could prove. And in the meantime, almost on a yearly basis, we see that more and more of these cancer cases have actually an infectious background. It's actually crazy. And that, of course, brings up all the discussions, you know, where's the origin of cancer and what type of diagnostics do we need? And do we have to prevent any kind of infection nowadays? So do more molecular testing and blah, 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 blah. Yeah, okay. So the fun part is here that although this looks all very complex, right? In 95% of those cases, the body just goes back to normal. It just defeats the infection. He defeats the precancerous niches. And that means, you know, it doesn't make sense to start here with cancer therapy because maybe you do actually harm instead of having a benefit. And even nowadays, you probably also read a few papers that even the diagnostics is super good with respect to breast cancer. People are getting more and more cautious to say, you know, let's take the breast away. Why? Because we have learned more and more that doing a more closer monitoring probably will do less harm to most of the patients. Yeah, some of the very aggressive, yeah. Remember the kinetics plot what we had, yeah? Some of the cancer cases just grow absolutely obnoxious. Worst case scenario is acute leukemia. Here you can literally die overnight. or anything like this. But they are actually very rare. In most cases, cancer is not something which kills you overnight, it kills you over years or decades. And the question is, where is my threshold where I say, now you should be treated? Or you're already so old, why should I treat you? It's one of those things. Good. So how would you then define a success? Again, success is that you're not dying. Is success that it is not growing anymore? Is success that the cancer has been shrinked? And for this, you also find actually all kinds of different versions of discussing treatment success. And this is not necessarily correlated to cure, what we just had in a slide before. So complete response, that would be something what we saw before after some treatment, and complete remission after 5 years. This is cure at its best sense. But in many cases, it is partial response, so just a little bit of less tumor mass you're having, a stable disease. It doesn't grow, but it doesn't shrink also. But it's perfectly fine. This would be most likely prostate, or progressive disease. At least some kind of a reduction in the tumor mass. But it's about mass. It's not about single cell and whatever. It's just okay. Instead of 5 kilos, you have 4 kilos now. Anything like this. That of course leads to the next obvious question: is all of these measures are defined by a certain diagnostic method, which is medical imaging and endoscopy. How large does a tumor need to be visible so that I can really get it via imaging or endoscopy? Yeah, of course. And the sensitivity of your method. But I mean, how many cells do we need to get an image? How many cells, roughly speaking?
So it's like a 3 millimeter ball.
3 millimeter ball?
I just thought about the resolution from CT, and I think it's like in clinical applications was 0.3 millimeter lowest.
How many cells are these? Roughly speaking. Is it 1 cell? Nah. Is it 1,000 cells? Nah. Is it 1 million cells? Soupy doopy, highly sensitive, best contrast ever? Maybe. 10 million cells? Yeah, we're getting closer to what is a real world typical sensitivity limit. Is 10 million cells early stage? Nah. Is 10 million cells cancer cells cure? Nah. Okay, so what are we talking here about? It's just a phenomenological description of what has happened after I did treatment. That's it. But it does not tell you anything about cure, with that one exception. But maybe this is also limited by the sensitivity of the method to really see contrast, which you can refer to a cancer or not. But the challenge is, of course, if you don't have functional imaging, you actually don't really know what kind of a grayscale value you're looking at. Is it really cancer, or is it something else? Down the road, you need to have the gold standard. Take a needle, get some sample out of it, and do the histology. That's the only way how to quantify if this was cancer or not. Back to the CAR T-cell story, what you saw before. Now you saw that this is a novel form of cancer therapy. It's super fresh and new, and we don't know yet everything about it. This paper came out yesterday, and I prepared that slide at 1 o'clock in the morning for you. And what you see here is someone was looking into, okay, I'm taking immune cells from someone. I do a genetic modification with it. I amplify it, and then I put it into an acceptor. And he was looking into 3 different forms of these CAR T-cell therapies. So 3 different bodies which have been created here in this chimeric fashion. And they looked into infections, viral infections. one of those little sneaky things about our viral friends is that they like to hide in immune cells, for example. Or they are so sneaky small that you can clean up as much as you want. There will always be a virus there. Why? Because we are living in a homeostatic condition with all kinds of viruses. I would say 1/3 of your immune system is only directed to defeat Epstein-Barr virus and cytomegalovirus. You've never heard about these guys, except you have a very low immune system response. Then these viruses kill you predominantly. But other than that, your immune system is only there to defeat constantly these type of viruses, and you can't get rid of them. It's like with herpes simplex. You have it, you can't get rid of them. And what they were doing is, because you're doing all of this manipulation and you grow cells under very awkward conditions, and then you bring those cells back into the human body, they actually saw that you recreated viruses, the ones which were silent and which were taken out from a donor blood, where you found those cells of interest and you did this amplification, this genetic engineering. And that's one of these learnings. When these products were certified, brought to market, they did a test, kind of looking good, but no one, literally no one, was looking actually for infections which you kind of co-cultivate with your CAR T cells. And the conclusion was, they used sequencing because they were not sure what to look for. And we're going to talk about sequencing at a later stage. But probably you should also use PCR-based tests where for very selected types of viruses, cost-efficient way, you would look for if the products are really free of any infections, and only then you would apply it to the patients in case these viruses, and this is now, I don't know, HHV, some freaky human herpes virus 6, whatever it does, could, for example, cause cancer. So instead of cancer treatment, you actually generate cancer. Wouldn't be not so cool. So that's about it with cancer as use case. Now let's have a look into that other topic we had, the troponin, the acute myocardial infection. You are with your grandfather at home, have a little bit of a coffee, and then your grandfather says, it hurts a little bit. And then he says, my arm is a little bit numb, or he has a stroke or anything like this. There are certain symptoms and people are aware of it. And what you would like to have now is to get these people as quickly as possible into a hospital environment where you can do a test if he really had acute myocardial infection. And what is this? So let's have a look at the mechanism. If this is the muscles, the muscle cells are huge, very stretched out cells. You have two major players. This is the myosin and this is the actin. And the glue between the myosin and the actin are these violet bubbles, or in a close-up, you see here actually many more of these smaller proteins. And they basically, depending on a calcium concentration, so low calcium concentration within the cell means no glue. High calcium concentration means glue. And in this way, myosin and actin is a kind of shifted against each other. And with this, I'm contracting my muscle. Okay. So when my contracting heart is having a defect and some of my heart cells are not working anymore, they will bleed out literally some of these proteins, which are super specific, organ specific only in the heart. I mean, you have muscle cells anywhere else in the body, but they are distinctively different, at least these gluing proteins. And therefore you call it also troponin T. This is a heart specific protein. Now you have a heart attack. You see here the concentration in some arbitrary numbers versus the days after onset of an acute myocardial infection. And if you remember last time we were discussing about kinetics, you would like to have a fast on kinetics, because when someone with a chest pain comes into the hospital, that is probably during the first day, you do a test and maybe he's somewhere here, right? And then you say, well, could be risk patient, and do another test maybe a few hours later. You see that the number is increasing, okay, which is usually a perfect result for you have AMI. So stay, and I have to treat you right away. As you can see, depending on what biomarkers you're looking at, but the most sensitive is this troponin, this glue what we're talking here about. You see that it peaks like 2 days after you had it. So even if there would be a delay, I would still be able to do a measurement. Okay, that's interesting, because not for every kind of a chest pain, you go straight away to the clinic. Even you had already a few times chest pain. And you always ask yourself, oh, did I have now a heart attack? No, it's just a little bit of a cramp you had. And then you have a not so quick off kinetics, where I'm also being able to check if I have been stabilizing the patient when I did all these interventions. And again, as you can see, as compared to many other biomarkers, what biomarkers this is not so important. The troponin T is the one which is the most sensitive. How do we do this measurement? Usually it's always the same. It's very simple. Depending on your interest, we can discuss this also in more detail. It's like with the lateral flow assay. You have a capture antibody and some kind of a carrier substrate. The troponin will be caught here. And then there's a secondary antibody which binds to a second position on the protein surface. And this secondary antibody has then some kind of a signaling molecule. So that's very close to the typical lateral flow assay, what you know from the SARS-CoV days. And this is true also for this type of a biomarker. Now, the question is this only true for acute myocardial infarction? And no, it's not. And as you can see, there are many, many causes why this muscle protein is being released from your heart muscle, leading to all kinds of variations of how these cells are behaving and how the leaking actually occurs. It's just a one-time leakage, it's a continuous leakage. What is it? Yeah. And therefore, it is relevant to understand that you have to look into the kinetics. That's the conclusion out of it. To have either early diagnosis or also early discharge. So you have some kind of an elevated value, but based on the kinetic measurements you're doing, I can say you're safe, go home, right? Or you're not so safe, stay here. And maybe there are a few false positives. That's perfectly fine. But I do a rule out measurement. What is a rule out measurement? Remember our graph here, these would be the non-deceased. Those were the deceased guys. And the rule out would be the level here to the point where this would be the least sick person I can potentially measure. Although I have a lot of false positives, but I don't miss anyone. Yeah, this is the rule out case. And with this, I can, perfectly do a test even within an hour after an acute care incidence, checking of what the hell is going on. The sensitivity of those tests, just to give you a little bit of a reference, it's truly obnoxious. So we can measure and now compare a little bit the number of cells you need to have for medical imaging. For a troponin test, we just need something like 20 ruptured muscle cells. 20. That's sufficient for us to do a quantitative test. This is crazy. So the smallest little incidents can be measured by us. Imaging has no chance against it. Even ECG has no chance. And that's also the reason why this is such an unique situation, that this biomarker basically replaced anything else as the gold standard test, basically, for quick testing. So, but what we've learned, it is the kinetics, and we have to understand also the baseline. And the baseline is, again, an age-related phenomenon. When you're young, you have a very low baseline. Why? Because your heart is strong and it has no defects. But the older you're getting, the more you get into the situation that your heart shows more and more failure rates. And that leads, of course, to ruptured cells. And it means your baseline over age will be growing. but the fast kinetics isn't there like with the acute case. So if you would just do a single point measurement, you know, you could for sure have a false positive, but you will minimize the number of false positives because you do the kinetics. And to give you a case where it is important, and this is now literally the research work which is currently going on. And after this, we do the break. This is heart failure. What is heart failure? It's a chronic disease where your heart loses the muscle power to pump basically the liquid through your body. And if the liquid is resting too much, those are the unfortunate guys who have a lot of fluid in or around the lungs, because pumping doesn't work anymore. And they cannot walk any stairs anymore, for example. They're not mobile anymore. Quality of life is really, really low. Can you treat them? No, it is chronic. You have it, you never get it away of it. What's the end situation? The end situation is in your new heart. Either you have a donor, then you're lucky. You don't have a donor, you get a mechanical heart, and then you have a few more months to live usually, and that's about it. The prevalence, and that's obnoxious, and very specific to a certain area of this planet. And that's the reason why we are there. In Singapore, it's not the poorest country you can think of. They have a prevalence of 4.5% of their population. Even more extreme is Malaysia. They have 6%. They have so many patients that they cannot actually treat them with the amount of physicians they're having. Get that. This is really crazy. And so what these countries really need is a simple decentralized solution of how to treat these people outside of the hospital. I can't, bring all these hospitals into my centers because the physicians will not be able to cover that. So I have to find solutions how to treat the patients basically at home. Do this fully personalized, and now use all my power of algorithm, my power of telemedicine, communication tools, and so on and so forth, to realize a situation where these numbers, and they are still soaring, they're increasing, they're not decreasing, as compared to the numbers which are relatively stable here in Europe or in the US of 2%, and to lower the costs per year. One of these patients costs something like 36,000 Singapore dollars, or some 30,000 euros. Times 4.5% of the population. This is huge. So there's a lot of opportunity there to really introduce technology and to test it out if there is a benefit by decentralized testing, but also therapy at once, right? Just doing the testing is probably insufficient, because if I test you sick, what is the next step you're doing? I go to the clinic. And that's exactly what you would like to avoid. And how to achieve this, it's not only true for heart failure, but for many other cases, how to avoid that sick people go back into the hospital system. This is the actual big challenge we're having. Why? Because this is where the costs are coming up for the healthcare system. We have to get them out of the clinical system, but still don't, generate fear that the patients believe, oh, I'm not getting treated well. That's the big challenge. Just think about your grandma or grandpa with the pressure meter. It's another brain cancer coming up. I need to go to the doctor. That's like with my mother, crazy. And that is the change, or this nudging effect, what we need to achieve, so that we are really having a chance to lower these conditions. Is this a very devastating disease? Hell yes. High mortality of 20 to 50% over a range of 5 years. So they take usually the same measures as in cancer. I was asking the Singaporeans, they also don't know. I'm for sure it is not related to the quality of food, because this is just obnoxiously high. I couldn't find any reason for that, and no one could tell me why this is. But 6% in Malaysia is just freaking crazy. Singapore is not really polluted, believe me. Also, Malaysia is not really that polluted. But there's a mix of Malay and Chinese population. But honestly, maybe we can ask our colleagues in the back. Are you from China? What is the heart failure rate in China? Do you know this by chance? it's less. Okay. Okay, right. And so I also couldn't get it out of it, but basically this is one of the projects what we would like to start in Singapore. And just to refer again to the number, you know, this is the technological challenge you have to master. That's this here. I need 30 minutes per patient per visit. But I have a prevalence of 4.5% in my population. And I have maybe, I don't know, 100 experts in the field of heart failure in the whole of Singapore. With, I don't know, they have 3 or 4 million inhabitants or so. How? Just doesn't work. And there's also a profitability perspective. I need to do at least more than 6 patients in a 3-hour shift so that I work profitable. I think the most extreme here, what I've heard was from an orthopedic. I had a little bit of an issue with my foot, and turns out that this was an orthopedic I knew from my student days. So after doing the therapy, we had a beer together right in his office. Loved it. And he told me that story that, you know, when I have a regular Kassenpatient, so, you know, regular patient and his health insurance, I start to lose money after 3 minutes. Seriously? And he said, this is just crazy. And I can't do anything, yeah, but I still have to treat this person. And then I'm always happy that I have a private patient, of course, because then I start compensating for the money I've lost with the regularly insured patient. And, you know, this is always the same throughout the world, unfortunately. So last slide, then we do the break, and then we have the presentations. There's a startup company just close by with whom we are also working pretty closely. It's called Adducor, and they have the therapy. So novel therapy, right? Now we talked about the diagnostics. We want to do the interventions. Usually the standard intervention is drugs to compensate for this congestion issues what you're having, so that the liquid is basically more or less well pumped through your system, and you're not suffering from too many side effects. But at some point in time, you know, the heart is done. And the problem is, if you get a donor heart or a mechanical pump, your blood will always be in contact with something which should not be in your body. And there's a lot of mechanical force. And that's the big issue what you're having with the heart. Meaning, you know, life extension is not that cool. So as long as you can still work with your own heart muscle, it would be good. It would be really good, because then there is no issue with the immune system. You don't have to moderate your immune system, and blah, blah, blah. So let's have a look what these guys are doing.